And more recently, while CDC reports that COVID-19 cases are actually higher in females, unfortunately, males are more likely to die from complications from the COVID-19 infection. We must continue to educate the public and providers everywhere about the importance of healthy lifestyles and early detection of men's health conditions. HHS does this in several ways, including reaching out at the state and local levels through regional health authorities to promote the importance of gender equity and men's health issues in the regions that each of us oversee. During National Men's Health Week, physical health should not be the only focus. This week also offers an opportunity to bring attention to mental health issues among men. Common areas of concern include depression, anxiety, post-traumatic stress disorder, and substance use disorder. Men also experience a higher suicide death rate than women. It's equally important that we recognize symptoms for these conditions and help our loved ones seek medical treatment when necessary. Across the US and the globe, we're seeing a rise in substance use disorders, especially during the COVID-19 pandemic. There's many reasons for this, but this could be due to the duration of the pandemic, physical implications of the virus, death of loved ones, prolonged isolation, loss of jobs, and many other factors. But regardless of age or age, men also are using alcohol and drugs more frequently and in greater quantities than women do. Understanding how substance use disorder differs between men and women is critical to optimizing prevention and treatment. One way we've seen an improved access for this treatment has been the expanded use of telehealth services. And we really look forward to the continued use of these services, as well as the emphasis on decreasing stigma to better allow those struggling to seek help. This is the time to highlight an awareness of, this is the time to highlight our awareness of men's health work. And I encourage all of you to take practical actions to overcome these concerns and build resiliency as we navigate out of this pandemic. This would include visiting your doctors and scheduling a routine screening test. Eat a balanced diet, get moving, walk a little bit more, visit with family or friends, try new muscle strengthening activities. Break habits like smoking or excessive alcohol consumption, and also check in with loved ones and reach out for your help for those struggling with mental health. Throughout Men's Health Week, we're all asked to come together to be part of the solution. With that, I really want to thank you for your participation today, for our great panelists that we have, both across the US that we have here, and again, across the world that are joining us today. With that, I'm going to hand it over to Armin. Thanks again and welcome, and get ready for a great presentation.
David, thanks very much. You touched on so many issues that we're going to be talking about in much more detail. I just want to emphasize one thing, though, in particular, which is we're talking about the pandemic, and over the past 15 months or so since the whole thing started, people have a tendency to think, a lot of people that I come in contact with, think that COVID is their only health issue. And a lot of people have put off getting any kind of other health issues dealt with. And they've let their diabetes medication lapse, and they've done all sorts of things that they shouldn't do. So we really, I think, collectively want to encourage people to, as we're moving out of the COVID era, to start thinking about their health more globally, and to remember that COVID is huge, but it's not the only thing going on. So just as a blanket recommendation. So I want to introduce Salvatore Gia Giorgiani. I think I've known him for 20 years, and I just stumbled over his name for the first time ever. He's a senior science advisor at Men's Health Network, and he's also the chair emeritus of the American Public Health Association Men's Health Caucus, and is somebody who knows a tremendous amount about all aspects of men's health. And Sal and I have worked very closely on a lot of things, including, and he's going to be talking about this in great detail, a series of conferences that we did under the auspices of PCORI, the Patient-Centered Outcomes Research Institute. Sal, why don't you give us your thoughts on where we're going health-wise? You're muted. Unmute yourself.
I always joke when I forget to do that. My wife's been looking for that button for the better part of 45 years, so no one tell her. If I could get to the first slide on my presentation deck, that would be great. Okay, thank you very much. I want to talk a little bit about a project that I did, but before we do that, the usual disclosures on the next slide. I have no conflicts of interest that are going to interfere with my ability to give you an honest and fair, balanced presentation. Next slide shows the genesis of the information I'm going to present. This was a series of monographs, detailed monographs, that were commissioned and graciously funded by the Patient-Centered Outcomes Research Institute, affectionately known as PCORI. They started off with a series looking at the very serious problem of mental health and suicide in boys and men in America. This is a problem that was alluded to earlier on that just is not getting better. We see men and boys have suicide rates over 4 times, almost 4 times that of women. And if you consider suicide as a mental health problem, it kind of makes the point that mental health issues in boys and men are a significant problem that needs to be addressed. As we went into our 2 programs, a general review of the issues and then the important ways that communities have to work to help manage mental health in boys and men, COVID hit, and PCORI was gracious enough to provide extended funding so that we were able to do a series of 3 programs on mental health issues, how they affect boys and men. And this presentation and the one that's going to follow by Dr. Evans will sort of summarize some of those key points. These are available to you along with a summary document at www.menshealthnetwork.org in the library. And I urge you, if you're interested in getting a lot of good, solid information, you take a look at these documents, which I think are well referenced and represent panelists from a broad range of expertise that are really expert in these areas. So on the next slide, I wanted to summarize a little bit of the information about the impact of COVID on males. The general mental health problems we see with male is really a communications issue. Many of the panelists believe that men and boys do express their emotional hurt and pain, but they do it in a way that's very different than women do. And individuals or folks, even in the clinical setting, who are looking to manage mental health problems don't really have receiving the messages that the boys are delivering. This problem has been exacerbated because of the isolation associated with COVID. And we also believe that post-COVID, as was alluded to earlier on, many of the individuals who have had traumas in their lives, their families, their finances, just the total disruption of so many aspects of our life, are going to have what many on the panel characterize as a post-traumatic stress disorder directly associated with COVID-19. We don't know how that's going to play out, but we do, the panelists, when you look at the range of the expertise on the panel, it's pretty impressive, do believe that in the clinical setting at the community level for primarily primary care providers, there's going to be a real challenge in recognizing the post-COVID era traumas and how to help men and boys recognize these and deal with these. Similar for women, so I'm not excluding women in any of this, but just we're going to focus in Men's Health Month in June on the guys today. Interestingly enough, one thing I'd like to point out is that CDC statistics and other statistics from diagnostic code harvesting show that 83% of males who commit suicide have never been diagnosed with a mental health problem. And that speaks volumes to the panelists that there is just not adequate screening. There are no guidelines for screening for guys for mental health issues. And it's just something that unfortunately insidiously grows until there's a boiling point. And these mental health issues not only can manifest in suicides, but also general violence that we also see happening in our communities and across the globe. So part of the underlying discussion in all of our conferences on COVID were these very important missing links to managing mental health in boys and men. The higher mortality rate, David brought that up. I think this is a global phenomenon. Last time I looked, of the and statistics are a little bit difficult to get in some areas, but overall, 58% of the deaths due to COVID are associated with males. Panelists believe, and others, from what I've read, also believe that a lot of this is because of the poor overall health of boys and men. In America, men die 5 years approximately younger than women do, and they live much less healthy lives. Of the 10 leading causes of mortality in the United States, men lead in 9 of them, and that's been historically the case for more than a decade, as far as I remember. So it's an overall problem, and we all understand that COVID is now making it worse. I think Armin and David both addressed the underlying notion that as healthcare pulled back during COVID because of the important needs for mitigation and the general fear of the public about going out, whether it's for cancer treatments, excuse me, important diagnostic criteria for underlying chronic diseases, many of which are comorbid factors to mortality for COVID, or they simply are not getting the care that they need, and they're not going out for care. So when I do radio interviews for the general public on this, I also talk about, just as we have to get our training wheels on and learn how to go out into the community without masks and slowly pull back on mitigation techniques based on the area we live in and guidance. Same for the healthcare environment. Those individuals who have chronic conditions need to get their training wheels back on, need to get back into the office setting or the hospitalizations and start taking care of those. Historically, that's a big problem for guys. Guys generally have only half the number of primary care visits during the year that women do. And only about 60% of guys can identify a primary care provider. They also tend to wait much longer on in their medical conditions to go seek help, even for painful conditions. So we have to not only reset to that not very good baseline over the next several months, but we have to try and address that underlying overall poor health issue, particularly in minority communities, that leads to this, we believe, higher death rate of COVID-19. Talk a little bit about substance abuse. I think David covered that. We are seeing a tremendous more amount of use of alcohol and other substances. It leads to a myriad of social issues involved in the home, in the workplace, in the communities, and these two need to be addressed. And when going back to one of the general thoughts that the panel had, is that this is all going to rest in the laps of primary care providers and community. So anything that organizations, HHS, departments of health, universities can do to help primary care providers understand the changes that they're going to see in their patient population and address those. And then also community organizations in schools, in the workplace. That is extremely important in the post-COVID era. On the next slide, I have a couple of more points to make. And I've been told that I will get the hook in a few seconds, so I'm going to do these quickly. A lost year, actually more now, of chronic care management, even in conditions such as cancer. One of our panelists represented the patient cancer organization, one of them, the research group. Research in so many areas, including in cancer, has been curtailed because of COVID. We're going to have to restart all of that effort. And a lot of that is getting people back in the mindset of participating in the important research work that's leading to additional cures and ability to manage care. I have a personal interest in this whole thing called COVID-19 long haulers. Again, looking at it from the primary care perspective, there are so many complexities to that. There are statistics that show that upwards of 30% of individuals who have had COVID, and that's a lot of people when you think of it and you run out the numbers, that's an amazing number of people, are going to exhibit some of these symptoms. We don't know whether it's going to be a 6-month thing or a year thing. Some are saying it may be lifelong. And part of that symptomatology of COVID long haulers are mental health issues, everything from fogginess to anxiety and depression. Here again, those who support primary care providers and those in the community who provide support networks for men and boys with workplace and schools, in the community setting, in social networks that have shut down, they have to have a good recognition of what they're seeing and not misinterpret it as flying off the handle or just some sort of minor problem. It could be a significant issue. And now on to a very important topic is vaccines. As the push for COVID continues, and still we see in the US up to 20% of individuals are resistant to getting COVID vaccinations. I think as we push hard on getting those individuals vaccinated, and then we get to the next phase, which is going to include booster shots, I'm pretty well convinced personally. I'll have to wait for the scientific community that makes these pronouncements weigh in. But I do think that boosters are a probability at this point. We have to reconvince folks. And as we start pushing out for boosters, we're going to get pushed back. And I think we're going to see a lower range, and the community needs to better address the concerns that have been expressed already with segmented type messaging. The other impact is on overall vaccination rates. Extremely important. Pneumonia, shingles, general childhood vaccinations. There's been a dramatic decline in those because of the lockdowns and the mitigation techniques. But then also people are now putting more scrutiny on all vaccines. So I think one of the bigger areas moving forward in later 22 and probably even in 21 is how do we get people to think better of vaccines as a necessary medical activity and fight the anti-vaxxers. But a lot of these folks are not anti-vaxxers. They've just been thinking about it so much that they become cynical and skeptical. So again, any support that can be given to the primary care providers, the pharmacists who have done an amazing job of doing vaccinations in the US to help them deal with this. They're not used to a hostile public about something as simple as vaccinations. I think that would be very, very important for the overall public health. So I think I am close to my time limit here. And Armin, are we doing questions after or now? How do you want to handle that, sir?
No, let's do questions after. I want to because we have the delay that we had in the beginning. Want to make sure we get everybody and everybody's in. But can you wrap it up now, Sal? Is that?
Yep.
Okay.
That's it. I think next slide is just questions and thanks.
Okay, that's that. All right, Sal, thanks very much. It's hard to get all this stuff packed in. We have so many great panelists and so much to talk about. So we're definitely going to get to questions. I want to remind people, by the way, to send your questions using the Zoom chat, or if there's a way of doing it on Facebook and getting questions to us, that we'll have them compiled and coordinated, and we'll spend some time at the end of the after everybody's presented to answer your questions. Want to switch it over to Jeff Evans. Jeff is somebody, he and I have been together at many meetings that were put on with Men's Health Network and a lot of other agencies and various places. And I always remember trying to somehow squeeze in there and sit next to Jeff for these things with my pen and paper ready to go, because I find that he says so many wonderful and so many interesting things, and he's got such a clear way of looking at men's health issues and how they fit into the overall healthcare issues in the United States and elsewhere. So Jeff Evans, he's recently retired as the former director of the Intergenerational Research for NIH, National Institutes of Health. He's a demographer and a economist, and really just somebody to listen carefully to, because he's got incredible things to say. Jeff, thanks for being here, and please do go ahead.
Thanks so much, Armin, and good afternoon to all. I'll just start my timer. When I was at NIH, it was convenient to think that we were the experts in health, and whenever we talked about something, we could stick to health and health policy, and that was a specialized domain of the government that was the only thing we had to worry about. However, the pandemic's changed that. It's moved health and health policy into the center stage of the economy and economic policy. Just to give you an idea of how important COVID and health has become in terms of economics. The foremost empirical analysis organization in the country is the National Bureau of Economic Research, affectionately known as NBER. And there are now 400 working papers and growing on the topic of COVID and the economy. That's 400 guys, top in their field, writing on various aspects of COVID and the economy. You can tap into that easily by hitting that link, or you can just Google NBER and COVID. But the point is, those working papers are free and they're timely. And if you want to catch up on what economists are thinking, really thinking, and not have to wade through a lot of theoretical obscurity, these papers are highly recommended. Next slide, please. We'll find that COVID has accelerated some processes and started some brand new ones. For instance, remote working has increased. It had always been there, but COVID has increased it to a point where people are starting to wonder, will people ever go back to working in offices and things like that? I mean, there are serious discussions about what the office place of the future is going to be. Personally, I think we've changed it rather permanently, and it's going to be a Zoom world. Also, online buying has increased while personal shopping has declined. Actually, the most recent consumption figures show a little reversal in that. It actually shows consumer spending going down because people are starting to go out to shopping centers again. But I think that online buying is here. It's going to be a big part of our future. We find that the industries have been affected in very uneven ways. Some have made a lot of money, others have gone out of business. Small businesses in particular are very vulnerable. A lot of them are really suffering. Even physicians. I just saw my primary physician yesterday, and he reminded me, my God, I can't get any help. Remind them that this epidemic is killing me. He got a little hysterical, but anyway, the uneven way that industries have been affected by COVID in particular, and our economic policies that have been reflected in COVID, is that industrial dislocation has occurred, and it's caused supply constraints. What does that mean? Well, I mean, for instance, take building new houses. Turns out that a lot of people have started to hoard lumber, and the price of lumber has gone through the roof. And now that we want to start building houses again, it's become prohibitively expensive. The labor market is surprisingly tight. If you take a look at the employment reports, you can see that there are a lot of people who are uncertain whether they're in or out of the labor force. Are they going to come back or are they not? Who will re-enter the labor force? The fact that we have so many people sitting on the sidelines is driving my personal physician crazy, So that's going to be a major question in the future. A big thing is that population is moving out of the cities and into the suburbs. Now, that had been happening before the pandemic, but the pandemic has made people really flee the cities. And as they are starting to get the idea that they can work comfortably in the suburbs, they want to settle in the suburbs. And housing prices in the suburbs are rising fast. That brings us to the number one problem. Inflation has increased. It's doubled in the last 6 months. If it does that again in the next 6 months, we're in real trouble. The stock market is currently betting on recovery, but everybody is watching the Federal Reserve, who's in action as we speak, and we all want to figure out what they want to do in terms of dealing with inflation. That's a big question mark. Personally, I think as the pandemic dies down, you can watch for an explosion of consumer activity. I know I'm going to join it. Next slide, please. Big question is, how will the economy react to our COVID policies? Well, we've, in general, injected a huge amount of money into the economy, but right now the production of goods and services is lagging behind. The common definition of inflation is too much money chasing too few goods. Does this imply inflation? I think it does. Extended unemployment benefits may slow the reentry of some in the labor force. As I say, that's important if we're going to boost the production of goods and services. A big question is what will happen to older and biologically vulnerable workers? There are a lot of them. The economy needs them, but they just may pack it in. This pandemic may have just chased them out. I know I lost a physician way before her time because of this. People who I contracted to clean my house, they're out of business and they're not going to get back in, all for that reason. I remain optimistic that the economic recovery will be pretty robust if the pandemic is contained, which I believe it will be, and inflation is held in check. And that's a big question mark. I am sure that the vulnerable, both economically and biologically, will need economic and health resources and help in the future. And that's a big question mark about how we're going to do it. Next slide, please. A major question is, will COVID-induced changes be permanent or temporary? I've got five that they're my big five. What will happen to travel, hospitality, restaurant, entertainment industries? They're in trouble. Will they come back? Will they come back differently? How fast will they come back? Will they come back at all? Next one is how much market share can online buying command? That's a big question. How would you like to own an interest in a shopping mall right now? You would probably be pretty worried. And conversely, will remote working persist? I think it will. Hopefully people will be able to meet in person pretty soon, but how much of that's going to be there? I don't know. Yes, will the population continue to move away from the cities? I think so. That's going to be a very interesting question, because that's a big thing that's slow moving, but it can change everything. And of course, the number one question is, what will happen to inflation? Right now, we're walking a razor's edge. On one side, we'll have a robust recovery and a happy experience with prices as inflation turns out to be temporary. But on the other side of the razor's edge is stagflation, and that's pure misery, and that takes years to deal with. So we live in interesting times, and during these times, we're going to find out what will happen. My guess is we're in danger of a real inflation. My hope is that we're not. Thank you.
Jeff, thanks very much. You brought it in exactly on time. I was worried about that. Our next panelist is, actually, I'm just wondering, I want to ask you one quick question now. I know we're going to save questions for later, but how do you, with so much of men's identity being tied up in economics, in being the provider protector, how much money we make, things like that, and because we're talking about men's health, I mean, how does that fit in there with that? I mean, it seems like that in some ways the economy is being affected by men's health, and men's health is being affected by the economy.
Yeah. And men and women are affected very differently. Women have been affected a lot by educational policy with COVID has afflicted us. But what do we do with all the guys who are sitting around wondering whether they're going to be called back or not? What's it do to a man that's sitting there wondering, I'm 58 years old, I got a heart condition. Do I really want to go back, or do I want to pack it in? I mean, that's a big source of anxiety.
Well, and also how that plays out in terms of substance abuse and suicide ideation and suicide accomplishment because of the confluence of all these things. It's fascinating. But want to get to Leith States, who is our next panelist. Leith is the acting director of the Office of Science and Medicine within Oash, and would love to hear what your take is on this. You're an MD and an MPA, so you've got the medical side. We've been hearing from the policy side and the demographics and economic side. So what are you seeing from your perspective, and how is it all going to play out with COVID and men's health, and as we move beyond?
Sure. Well, thank you very much for the intro, Armin. Did I get anybody else hear that feedback?
Nope.
It was just okay, good deal. So let me just park here on this slide for a moment. Armin just mentioned MD, MPH, and I think we all we get caught up on the titles associated with these slides, I think. If I had to be honest and just, take my vulnerable moment, I would tell you that I suffer from depression, from combat PTSD, from childhood PTSD, from substance use disorder, and I've been in sustained remission for almost 2 years now, from bipolar 2. And those are things you just do not see, because as men, typically, we do not go beyond the surface. So just take that as my first step, as, taking a step towards vulnerability with you all. So on that note, I'd like to say thank you for attending, for being part of this discussion. Hopefully that gives you a little bit of a look behind the curtain of just, we got another doc. What's he going to say to me? Hopefully I can speak something of truth, something of lived experience that's useful, that'll add to some type of developing framework and answer questions that you might have. Let me go to the next slide, please. Okay, so next slide in the interest of time. So let's park here for just one moment. This is our level set, the usual epidemiology, what's our current status? We know that there's an increasing proportion of men that are in fair or poor health in the United States. Heart disease, there's no way getting around it. It is still the leading cause of death, and it's going to continue to be the leading cause of death. If anything, as we start to see, greater upstream associated risk factors that lead to downstream poor health outcomes, we may start to see an even greater exacerbation of the resulting deaths due to heart disease, which now we see that at least a quarter of deaths in the US for men are due to heart disease. And the usual players of malignancy, and I think Sal and Armin mentioned this earlier, and I think David did as well, with regards to lapses in screening, lapses in personal ownership of health, and even the willingness to step forward, leading to decreased surveillance and downstream poor outcomes. We have increasing obesity rates. There was a question that came in about gender, so let me answer that for a moment, because I think that's a really important piece. Speaking as a master's in public health, I put on a little bit of the nerdy public health hat from time to time. The demographic data and the capture of that data is so poor and incomplete. Sometimes we can't speak to gender versus sex. So I apologize, in my here with regards to inequities persisting between genders, I should have put sex there, right? I can't speak to identify gender identification because it's not asked for most data capture. So that's something that speaks to a shortfall of public health and healthcare, and it accounts for an underserved and inequities and downstream health disparities. So I just wanted to take a moment to recognize that, and then just recognize that even within male sex, we have race, ethnicity, socioeconomic, persons with disabilities, education level, MSM status, whatever it can be. It's not just a one size fits all for men, right? There's a lot of different risk factors and a lot of things that put us at variable risk for different outcomes. Some things are common, but there are things that are different. So let's go to the next slide based on that. And I'll try to keep these short, since I know that we got compressed on our timeline. I'm just giving you a snapshot of work that we've been doing in Oash, and specifically within my shop in science and medicine. This is something that's been related to increasing equity in health tech utilization for aging populations. And this may get to Sal's point. I think he mentioned long haulers in his talking points. When you have baseline poor health for men as compared to women, the increased share of morbidity, mortality has been overrepresented in men. And I think that there is an opportunity with some of the things that David mentioned, telehealth, other rapid adoption of health tech, that's allowed for some novel and creative ways to get health solutions into the hands of patients that need them. Rural, urban, persons with disabilities, folks that are essential workers, folks that have transportation limitations, that need to have access and develop that self-efficacy that they're not given the opportunity to because of the existing pre-COVID inequities that have just been widened and put on full display. To that point, one area of work that we've been doing in Oash is surrounding, like we said, this equity piece. And we put out an RFI back in December, and we ended up doing a very quick analysis that gave us some emerging themes. We've been able to get a few pieces out on HHS in blog format and in JAMA. And what we're working on right now is a collaboration with the Medicare and Medicaid Innovation Office to work on a model for improving Medicare Advantage. And I know Medicare Advantage may be a new term, but essentially that's kind of the new way to contract medical care and decrease cost as compared to an old fee-for-service model, right? So working with new Medicare Advantage providers to see what they are doing to help get tech into the hands of aging populations that need them most. And most frequently, that's for men. Next slide. Okay, I won't spend any time here, but suffice it to say, the linkage here that I'm trying to show is that cardiac arrest is a really important consideration for men's health. especially for the pandemic due to cardiovascular disease and overdose death. Let's go to next slide. And this is just showing the underlying inequities for Black Americans that undergo a out-of-hospital cardiac arrest. My heart stops while I'm out on the street. They are 2 times as likely to die, but they are 50% less likely to receive bystander CPR. I'm not saying the why there, it's just an association, and it's something that should be changed and investigated further. Next slide. Okay, I'm going to hit pause on this one and just say for climate change, when we look at it, it's stressors to our system, a pandemic, climate change, a natural disaster, a stressor shows what we really are, right? We showed that our public health system is inadequate. We showed that the health system is inadequate. Same thing as we're starting to see more climate change effects take place. We're going to see the most vulnerable being impacted. And a lot of times that's going to be the people with the pre-existing health conditions. So I bring that back to the usual mantra of men will likely be implicated in a more serious fashion, along with children and elderly. So next slide from there. All right, now to the quick bit of meat that I want to leave with you. We're all fully aware that vaccination rates are increasing. The Biden administration wants to get to a 70% vaccination rate by July 4th, Independence Day, and all that good stuff. One thing I want to just hit on is there's something in the news that may be of interest to you all. Recent cases of pericarditis, or inflammation of the heart, in adolescent men that have received their first and second doses of the Moderna or the Pfizer vaccine. And this has actually resulted in an emergency meeting by the CDC to address this through their ACIP mechanism, which is the group that pretty much tells you if it's okay or not okay to apply or use immunizations in a given setting. So right now, the guidance is to continue and press forward. The risk of getting COVID and transmitting to others is worse than the risk of getting the pericarditis, which resolves and no deaths have resulted from it. The other point I want to mention is the Delta variant, which is starting to creep up a bit more in our news cycle and our news feeds. So the bullet points there are, it's more transmissible, it's more severe, but the existing vaccines that are on the market approved for use, it is just as effective. So again, we get back to the point of, well, we have existing tools in our public health toolkit. Let's use them and find ways to address the communities that aren't using them effectively. So the last piece on the vaccines then, because it's really hard to do behavior change when I'm not the person you're in a relationship. When I'm not the provider, you're in a relationship. I'm not a trusted agent. But what you can do is understand that they are free, they're easy to find, everyone is eligible, and the information I provide there can lead you to that right trusted resource to get in and get the vaccine process started. Next slide. Okay, behavioral and mental health. And I will finish this up quickly. So suicide rate has decreased, and this is CDC data, I've hyperlinked everything for you, by 5.6% as of 2020 compared to 2019. That's misleading. The data is going to continue to be cleaned, so it's probably going to go up. And it doesn't provide any demographic breakdown, so we don't know how bad it is for the communities at greatest risk. Overdose deaths, on the other hand, those have jumped over, well, nearly 40% compared to 2019. And following on with what Sal was saying, a study in JAMA that was, I think, by the Canadian health system showed that over 70% of their overdose deaths have been in men during the pandemic. And this, again, has been supported by a JAMA article that was from UCSD or UCSF, excuse me, where they demonstrated, racial, ethnic minority communities, Latinx, and Black communities accounted for a disproportionate number of these suicide deaths. And we think of essential workers, transportation issues, increasing stress. not having access or associated with excessive stigma that's keeping people from getting the resources they need. So the last piece there for what Oash is doing, we're working on a now secretary level behavioral health coordinating council that's going to be addressing these issues for vulnerable populations. And I think it's very important to realize that as we go forward, and let me highlight something that Sal said earlier, for tribal populations, adolescent youth, American Indian, American Native populations, they had a 4-fold suicide risk difference as opposed to Black youth. And that's even greater than non-Hispanic youth and white. So in terms of allocating resources and knowing where the greatest good can be done, I think you said missing links. We need to find those missing links and make sure that these populations aren't forgot. Next slide, please. And it should be the last. All right. Everybody likes The Rock. So I thought I would stop with a quote from The Rock. I found that with depression, one of the most important things you could realize is that you're not alone. You're not the first to go through it. You're not going to be the last to go through it. This applies to anything in men's health, right? Heart disease, diabetes, HIV, mental health issues, suicidality. We're not alone. Take that for what it's worth. Hopefully this can be useful to you. I will attempt to make the slides available with some of these links. And thanks for your time.
Lee, thanks very much. I want to say there was a comment that came in, and I was going to say exactly the same thing, that hearing from somebody who's in the field, that he has gone through a variety of different mental health issues and struggles, is incredibly inspiring, because I think a lot of us have a tendency to think, particularly guys, think that we're alone, that we don't have problems. And I'd host a radio show on the American Forces Network for service members, and had a chance to interview the Sergeant Major of the Army who had some significant PTSD issues. And I got so many comments from people saying how inspiring it was to hear from somebody in a position of authority that not only did he have these issues, but you know what? He asked for help and he got it. And that's one of the biggest things. And Sal touched on this before, we can get into it later, about the lack of screening that's available for men. We have a tendency to think that we don't have problems or it's a sign of weakness. So thank you personally, as somebody who also struggles with some of the same depression and anxiety issues. It's nice to hear that I'm not alone. So let me get to our last but not least panelist, Anna Tomšić, and she's going to wrap it up and talk about Men's Health Week and Men's Health Month, the history and what we are trying to accomplish at Men's Health Network, and to bring this around. I just also wanted to add something I didn't mention at the beginning. I should have had this major disclaimer about the panelists that you're hearing from are all expressing their personal opinions and not necessarily those of their employers. So keep that in mind. And also, this is really intended for stakeholders and individuals and colleagues. We're not considering this to be a press conference. If you'd like to ask media questions, please contact Oash. They've got a press office, or Men's Health Network directly. And or you can send me a message and we can set something up to figure out how to do that. But if we can keep reporter questions out of it, that would be great, and just deal with individual folks. So Anna is the vice president of Men's Health Network, and it's has all, for the many years that I've known Anna, it's really reaffirmed in my mind the fact that men's health is a women's issue, and she brings that perspective in addition to many of her other interesting perspectives. Anna, thanks so much.
Thank you, Armin, and thanks everyone for joining us. Good morning, good afternoon, depending where you are. I am here to talk about Men's Health Week, and happy Men's Health Week to everyone. This is a very big period for us at Men's Health Network, but across the country and across the globe. I know we have some international partners that are participating as well. Next slide, please. A little bit about us. Men's Health Network was founded back in 1992, and we have a large presence across the country and across the globe through different partnerships. Our main mission is to reach men and their families where they live, work, play, and pray. So we do that by going into various locations, workplaces like John Deere's, Harley Davidson, UPS, churches across the nation, and working with groups on a local level, so local sports teams or national sports teams. We do a lot to try to reach men where they are, because that's where they're going to be more comfortable. Our main mission is to get men's health to be just as widely recognized as women's health issues are, not to take away in any way, shape, or form from women's health, because we feel that men's and women's health are equal, not just on sexual and reproductive health, but issues across the board. Men help women with cancer diagnoses and with different support methods, just as women help men, and they help with, maintaining their health individually. So we provide a lot of educational materials. We do events like this, webinars. Our social media is very busy, especially during this month, with educating about different men's health issues. So we cover men's health, not just below the belt issues, but all across the board. Fatherhood issues, mental health, as you're hearing about now, a lot with COVID and vaccinations over the past year, just trying to get men more involved. And I started at Men's Health Network 10 years ago, well, 11 years ago now. But there's been such a huge change from 11 years ago, where when I would go to an event and I saw, what men were thinking, or what they would tell me what they were thinking and how they felt about health, to where it is now. So I think that's a huge change, and I think it's a change in the right direction. We just have to get them to be a little bit more comfortable with that. Next slide, please. So Men's Health Month initially started back in 1994 with Men's Health Week. It was signed into law by President Bill Clinton with the help of Bill Richardson and Bob Dole. And we had a lot of people contacting us because throughout Men's Health Week and month, we encourage people to do different activities. You can wear blue, you host a health fair, encourage your staff to get their screenings done, host health screenings at your location. And a lot of people were contacting us and saying that we don't have time to do it during this week. Can we do it later in the month? So we expanded that to be a whole month worth of activities, in which we have a toolkit for people to use. We have information, posters and flyers. We send materials to various organizations across the country, including churches, who are putting together information for their members. And especially after the past year that we've had with COVID, we have done a lot more on social media. So right now we're doing Twitter chats and webinars and participating in a whole lot of different activities on social media. So we hope that everyone can participate in that. June is the flagship month for Men's Health Month, and this the week, National Men's Health Week, is actually recognized internationally by a lot of our partners, Australia, in Germany, in the UK, Ireland, Italy. So we're across the board working with all of the different countries to try to bring men's health to the forefront. Next slide, please. So this is some of the digital media things that we're working on right now. We would invite everyone to participate in whatever way you are able to. I have the hashtags listed there that we regularly use. For this week in particular, we have the Men's Health Week hashtag. But Men's Health Month and Wear Blue throughout the month. Something that is really important that I encourage everyone who is on this webinar to participate in is tomorrow's Wear Blue Day. Wear Blue Day was started a few years ago, where we encouraged companies and different organizations to encourage people to wear blue on a certain day. Some companies that we work with tell their staff, if you want to wear blue, then put a donation, $5, free dress basically, and then we donate it to Men's Health Network, which helps us in furthering our mission. So we encourage everyone, tomorrow is National Wear Blue Day, but anytime during this month, wear blue, use the hashtag Show Us Your Blue, and then post photos on social media, tagging us, using the hashtag, and saying why you wear blue, who you wear blue for. In the next couple slides, you'll see there's some images of different things people have done. But we participate in different, like I said, Twitter chats and different social media events. We do have a Twitter chat coming up on June 24th around mental health. So that one is going to be in the afternoon. That'll come out in our newsletter. So if you're not part of the Men's Health Network newsletter, please go to our website and sign up to receive the newsletter. We also have, and the information should be on the website as well. On June 24th, we have a congressional briefing that we're working on, again, with mental health as the topic for that in COVID. So that will be, I believe it's at 11 a.m. on June 24th. So that will be a little bit different because we're not used to doing congressional briefings that aren't in person. We've been doing those in person for all the years that I've been there. And, you know, invite everybody to participate. Send us a message if you have questions or if you want to participate in one of these events. We're happy to have you guys join us. Next slide, please. So these are some of the ideas. The theme for this year is wear blue and a mask too. I know that CDC has changed guidelines on mask wearing, and you know, we still encourage people to be safe. And if you don't feel comfortable, please wear your mask. But here, excuse me, you have images of different office workers, parents who dress their child up in blue. I put my dog in blue every year. And so, you know, we want to recognize the men in our lives and recognize that women, although, you know, there are different awareness periods throughout the year, physically women can't grow a mustache, but we can wear blue and we can do things to, you know, show why we support our men. Next slide, please. Public officials, things like this event that we're doing now with HHS, we get proclamations submitted to us from different states, governors, tribal nations. And so we're encouraging people to recognize this week as Men's Health Week. And then what we do is when we get back to DC, the information back to DC, we try to reach out to the congressional members that are in office in DC and ask them to do photo ops and recognize the awareness period that the governor or the mayor in their state has acknowledged. We do events with Congress in which we list, show those proclamations as well, and then federal, state, and local programs that we do in trying to encourage it. So across the nation, if you see an event going on this month, it's probably in collaboration with us in one way, shape, or form, and we have materials that we provide for that as well. So if anyone's interested in hosting a Men's Health Month event sometime for the rest of this month, please feel free to contact us. Next slide, please. And this is the contact information. Want to make sure we have time for questions. So please take note of that. If you guys have any questions, please reach out or in the chat or via email. We're happy to help out. And happy Men's Health Week.
Anna, thank you. That was packed an awful lot in there. So Men's Health Week is something that's been going on for, as you said, more than 20 years, and it's great. We've have a tendency to think that not a whole lot has changed, but it really has changed a lot in terms of acceptance of men's health as an issue. Is David Johnson still on? Because I think that was a question that, speaking of the issue of men's health and Men's Health Week, we've been talking about this offline, and again, just as this is not a policy question, not asking you to answer on behalf of your employer, but one of the issues that comes up for a lot of people is, well, why don't we have some sort of government-sponsored Office of Men's Health or something like that can really put men's health issues on the forefront? Because as we've talked about, there's so many issues where men are disproportionately affected negatively by shorter lifespan, by suicide rates, and then as Leith and Sal were talking about with overdose deaths and violence and so many other things, obesity. Why are we not focusing on that on a policy level?
Right. So, yeah, I think when we start looking at the question, there's also another question I think that's related to this is sex and gender and inequity, and when we address it that way. One of the things that I think the current administration is doing, and again, another question came up about Gender Policy Council, is actually looking how we can address this together as we're doing it right now. The Gender Policy Council and health equity is a huge drive of this current administration. And I think it really supports the foundation of what we're talking today. Sal, Jeff, Leith, and Anna all address this comprehensively. When we're trying to address both sex and gender differences, we have challenges. We know they're there, but our data are not good. There's a couple different executive orders, and I'm not getting too, I don't want to get too deep into the weeds on this, but there is an awareness from the foundational perspective of how to improve this. I think looking at it from an Office on Men's Health, I think that's also another, that is something that I think would be an appropriate step to really address and put it more at the forefront. I think as you raised, Armin, there's been a couple other successes in some. I think IHS has an success there. Unfortunately, I think the actual operations of it is always difficult. So part of the weeds is challenging, but I think addressing sex and gender, there clearly are inequities there and there are differences. Right, when we and I also apologize that we often, I think today, and we didn't do it purposely, or we also didn't do it without the understanding that there is a difference between males and men, and females and women. And thinking about sex, when we really think about it as the biological side, or at least for this argument, right, or this discussion, and gender and the social constructs certainly are gender differences, or I'm sorry, sex differences. But I think when we are trying to address it today, both in Men's Health Week and other issues related to this, I think the social constructs both increase and decrease the impact that health and the environment has on genders. Again, positively and negatively. We have both reinforcing behaviors and reinforcing gender difference in social constructs that actually improve our health. And we also have many of them that actually decrease and make them a little worse. But to get back to your original question around an office on men's health, I think that is another one of our tools, I think, to be able to ensure that we're looking at health equity so that, right, all a rising tide raises all boats. It's not one against the other. And I think as we've talked many times before, the office of a men's health or an office on women's health really is there to help support and improve gender equity, really address some of these inequities, but also inequalities when we think about policy, right? We can think about it that way in funding. So apologies for going a little bit too broad on that and getting on my own soapbox, but as a proponent for gender equity and for decades, it's really critical that we actually approach it from that perspective. And again, in honor to that question, I think it's important to look at it from that perspective of having gendered offices that actually work together and not separate.
Yeah, Leith mentioned this, and it came up a little bit with Sal as well, that you can slice things in so many different ways, that there's talk about how African Americans and people of color are more likely to be affected by COVID, but within that group, men are more likely than women. But then within the group of males, there are so many different areas where people in rural communities are more likely to be affected than people in non-rural communities, or people who are unemployed are more likely to be. So you can just slice these things until you end up with, it's very difficult to keep track of it. But Leith, would you talk about this a little bit, why is it that Black men in particular, and generally men of color, are more affected by this? And then also, if you could talk about the issue that came up just very briefly, but I think is important, of vaccine hesitancy. I'm in California and was talking to some health people out here and about trying to do something to improve vaccines. And we happen to be in Marin County, where I am, is apparently the most vaccinated county in the country. So we don't have a problem like that, but there still is, as Sal mentioned, there's a hardcore group of people who are just not going to do it. And money doesn't even work. I mean, they're trying to give them gift certificates to go get, it's just not working. And how does that overlap with the vaccine hesitancy in the Black community and other communities of color?
So thank you for asking, Armin. So just to add to the California theme, I am from Southern California, so I'm still learning how to be in DC. So I can speak to the experience of just giving an anecdotal. My father is Black, and I watched him, as much as I saw of him growing up. He was a man under stress. He was a man that had 4 heart attacks and never sought care, and just continued working through it. He is a gentleman that is very proud by just his nature of being former military, but at the same time, and I'm going to follow up on this, so I'm not going to leave the term mistrust to hang out there, but there's a lack of willingness to entertain the thought that providers or the public health professionals or health system in general has his interest at heart. So it was an act of Congress or moving mountains to get him to go in for a 4-vessel bypass because he was going to die otherwise. So that's just an anecdote of where I see Black men come from my own experience. Speaking to what I've seen recently with vaccine hesitancy and the more broad consideration of the Black community, I think an easy out, a scapegoat term for a lot of health entities is mistrust. Oh, because XYZ doesn't trust us, well, we offered the vaccine. If they're not going to take it, well, then that's their issue. We can only do so much. Yeah. But I think that there is a wider consideration of and this will be me bringing in the institutional or the systemic, the structural discrimination, and just the fact that this is not happening in the vacuum. So granted, there's mistrust, but there is a reason for the mistrust, and to acknowledge that mistrust and to understand where that lapse in willingness to engage outside of the other social determinants factors that serve as barriers. There are things that are external to, that are just part of the built environment that keep those communities from engaging in care. Transportation, education, working, work status, a whole variety of other issues that are identified and established as barriers. The other piece of that is the historic, or where folks are coming from with their perceptions and history of personal experience or informed from the broader community. So there are mechanisms, I think, to break through some of the highlights. And I think there was somebody on the string here mentioned rural communities as, being a hotbed for some of these issues. And I agree, vaccine hesitancy is right there among them. There are some models that are bearing fruit, and that's why I went, and they have to do with having a trusted agent from the community, right? You understand that, and this gets to the fact that not all communities created equal. They don't have the same way to accept medical advice or expertise because there's a different framework and a different perspective. So I think that gets to the point that when we come to these communities, and I'm losing my train here. I had something and it was going to be good, and now it's going away from me. But I'll stop by saying that the only way we can get into communities is by having a trusted agent, and without a trusted agent, you're not going to build the bridge that's necessary.
Yeah. We're right exactly at the time that we said we were going to end this, and because we had 10 minutes of tech issues at the front end of this, I'm hoping that people can stay for a few more minutes. If you have to go, want to be respectful of your time, but if the panelists are okay to stick around for another 10 minutes or so, there are other questions. To pick up on what you were saying, you mentioned the rural communities, and there was a question that came in about for those communities in particular, but other communities, you could slice it to people who are transportation impaired, for example. They don't have to necessarily be in a rural community. Aside from telehealth, which Sal talked about, and I know we addressed this in one or two of the monographs, Sal, what kinds of recommendations do you have for how people in rural communities or other communities where they are going to have difficulty with face-to-face encounters with a medical provider, how can they, first of all, dealing with the COVID issue, how can they deal with that, get the vaccines, but also how can they get back to getting their healthcare issues, whatever they are, resolved? And
in terms of overall healthcare, telehealth is an extremely important component for many in the rural community, particularly for guys who, I think one of the reasons guys don't go in smaller communities is because waiting rooms are open. Their boss might be there, their neighbors might be there. I think that environment feeds into the inappropriate but real stigma that I don't want anybody to know that I'm ill. Telehealth provides a tremendous amount of anonymity. Having said that, part of the infrastructure problem that needs to be addressed, and I know both public and private sectors are working on addressing this, is the ability for those in rural health to have good, stable, reliable internet services. We suffer from that ourselves sometimes in our own urban communities. So that needs to be addressed. But then the other thing that is important, and the panelists pointed it out a lot during the discussion, is that there has to be reimbursement equity for telehealth and telepsychiatry services and remote data monitoring, which is an amazingly important use of technology. There has to be reimbursement equity, otherwise providers and healthcare organizations are just not going to adopt that, and the default will be, well, come into the office. And we kind of know that didn't work very well for the guys overall, and certainly in the face of the new reality of, well, I didn't go to the doctor in a year and a half, I'm just fine, why do I need to go now? Mentality, which is wrong, but prevalent. That's helpful. There are options. There's just telephonic consults, which aren't as efficient, but that can be done. So in terms of vaccinations, one of the most important things the administration did, and I'm a doctor of pharmacy by training, so of course I advocate for my profession, is have vaccines being delivered in pharmacies. It's totally important. You have, in some communities, even rural communities, 2 or 3 vaccination points in every community that are very accessible, open a lot of hours, weekends, nights. So I think that that's, when we look at other ways of delivering health care, utilizing that important healthcare resource is one of the considerations that have to be given. Of course, unfortunately, pharmacists are not considered providers, so they can't bill for the work that they do. It's just an administration fee. And I think that too must change because these folks can really do an awful lot of good in so many areas of healthcare. I hope that helps.
Jeff, I want to ask you from an economics perspective, because you mentioned one of the things when you were talking about how certain businesses thrived during the pandemic because they were getting more business and certain businesses went out. And some of the ones that went out were, in particular, were healthcare providers or healthcare broadly speaking. They're physical therapists or small labs or sole proprietor physicians, primary care physicians, which in a way, not in a, well, in a very direct way, has limited people's access to healthcare. All of a sudden, they're not going to be able to get the physical therapy they need, which is going to play out economically, and people won't be able to go back to work, or they won't be able to get the regular screenings they need to do. How is that going to play out for us long term, do you think, or even just short term, as we get back to normal, such as it is?
Well, what you're talking about are supply chain kind of limitations. I mean, I hope they're going to be temporary. I mean, we're betting that as a country that the markets will begin to start functioning normally, and things will get back to normal within a year or two. That's our hope. But there are some places that have been really, really damaged. And you mentioned a couple of them, especially in rural areas. It's going to take a while to build up that capability. So I would say we're in for a rough year and a half or 2 years as we try to rebuild this capacity. And that's going to be a problem for all of us, I believe.
Well, I think we're just out of time, even our extended time. So I want to take just a moment and thank everybody. Thank Jeff Evans and Leith States, Anna Tomšić, and Sal Giorgiani, and David Johnson, of course, who has been working with Men's Health Network for a long time on doing this. And this is the first of hopefully a series of webinars on men's health, various aspects of it. Something that we all feel collectively and individually is something that's really, really worth dealing with. And there's so many issues to talk about. Glad we got to talk about some of them. There are a lot more questions, but we'll have to save those for another day. So again, thank you very much. Thanks to Men's Health Network and the Oash, the offices and the individuals involved for helping this all together. And of course, thanks to the panelists for your questions and your attentiveness. Thank you.
Appreciate it, Armin. Thank you for everything as well. All the best, everyone, and happy Men's Health Week and happy Father's Day for all those coming up.
Thank you all.